Hello, good morning everyone, and welcome to Breakfast at UMHealth. My name is Dr. Mariana Nabilah, Medical Officer from Department of Surgery, and I'll be moderating today's session. So today's topic is the critical role of pre-habilitation for positive post-operative outcome. It's my pleasure to introduce our speaker, Dr. Wong Wei Jin, Senior Clinical Lecturer and Consultant Upper GI Surgeon here in UM. So Dr. Wong completed his Master of Surgery here in UM. He went on to complete his advanced fellowship training in D2 gastrectomy and also vasectomy in Japan, as well as a metabolic and bariatric surgery in Taiwan. He currently serves as our consultant upper GI surgeon here in UM. And without further delay, I'll just hand it over to Dr. Wong to talk us through today's talk.
Hi, good morning, everyone. Thank you so much, Mariana, for the introduction. So the title of my talk today is, as mentioned, the critical role of pre-habilitation for positive post-operative outcomes. And just let me share my slides. Without waiting anymore, let's get right into it. So this is the outline of what I'll speak about. We'll start with a quick introduction. I will briefly outline what we think the problem is, my proposed solution, and finally some conclusions to this problem. So going straight into the introduction for today, we end up asking ourselves as surgeons, what often is the purpose of surgery? And as surgeons, sometimes we do lose our focus a bit, and we often see the patient in terms of anatomy, whether there's a tumor that can come out, whether there's something that needs to be routed, a perforation that needs to be fixed. So we tend to look at our patients from an anatomical point of view, as just a roadmap and what needs to be fixed and what kind of plumbing needs to be done. Unfortunately, this is not quite true, because we know that the patient is more than anatomy, and we should be focusing instead on the patient's physiology, which leads us to the two main pillars of our main purposes of surgery. So oftentimes when I teach the master students, we do this thought experiment on what it is that we are actually doing when we perform surgery. So any sort of surgery, that the eventual aim and outcome of all surgery is actually to restore normal or near normal physiology. We know that completely normal physiology is not always attainable, but near normal physiology is. So the first pillar of all surgery is that we aim to restore normal or near normal physiology, which is a bit counterintuitive, because if you think about it, surgery is actually controlled trauma. Whenever we put a knife on someone, we are inducing trauma to that particular person. And the issue with trauma is that it is directly correlated with surgical complexity. So the bigger the problem, the bigger the surgery that we do, the more the trauma there is. And it's also directly correlated to the physiological derangement that the patient will have. So very counterintuitively, if the aim of surgery is to restore normal physiology, but surgery itself causes physiological derangement, how do we justify what we are doing? A simple graph taken from publication many years ago shows us that the patients demonstrates that the patient's basal metabolic rate, or the metabolic demands on a patient and the physiological status deviate significantly from their normal range in accordance to the amount of trauma they have. So if you just look at this, if someone has minor trauma, then there will be a minor derangement. But if there's major trauma, then there will be some major derangement in terms of their physiological baseline, assuming that the baseline is there. So in essence, if we do big surgery, we get big trauma. But if we do small surgery, then we get small trauma. So surgery is controlled trauma. It leads to a stress response to the patient, which leads to significant physiological deterioration, which can manifest as SIRS, metabolic changes, as well as increased cardiovascular, respiratory, and renal demands onto the patient. So besides the trauma that's induced, the physical trauma that's induced, we have to remember that there's also anesthetic considerations, there is cognitive derangements, and there is psychological stress, and all leads to further functional deterioration of the patients. So the question is, why is this such a big deal? Why is functional deterioration, as mentioned here, why is functional deterioration such a big deal? Because in the critically ill period of our patients, especially of the complex patients that we operate on at University of Malaya, we see that individuals who are critically ill, or those who are in the ICU, or those who undergo major surgery, experience about 20% muscle loss in 10 days. And this was taken from a publication in JAMA some time ago. But the big question is, so what? Why are they losing muscle in the first place? And very simply, they're losing muscle because the muscle itself is catabolized to produce substrates for wound healing. So in an individual with a non-healing wound, basically there's not enough substrates, not enough building blocks for the wound to heal. And if you have more muscle, basically, what happens is that the muscle can be catabolized to provide substrates for the healing of the wound. So the more muscle you have, essentially, the more building blocks you have to heal whatever surgical wounds have been inflicted. Comes back to the question, so what? So what if someone goes from looking like this to looking like this and losing a significant amount of muscle while they're ill? And the question of so what has been answered in many publications done before this. Taken from the Journal of Surgical Oncology, there has been an association of sarcopenia and post-operative complications for any sort of GI and HPV cancers. And what was found by these researchers was that out of 210 patients, individuals who were sarcopenic were 6 times more likely to develop major complications. Similarly, in colorectal cancer, 142 patients, major complications in patients who were sarcopenic was up to 58%. And major complications in non-sarcopenic patients was only 24%. And in the diseases of esophagus, this is a journal that we ourselves published in. So we managed to publish our Malaysian audit in this journal, looking at esophageal surgery, which is primarily what I do. When we looked at 227 patients over the course of almost 10 years, we found that the major complication rate did not differ that much. So those who were sarcopenic had a major complication rate of 43% versus 53%. However, in our particular audit of Malaysian patients, we found that the 30-day mortality was very, very different. So in individuals who were sarcopenic, the mortality rate was 21%, and in those who were not, the mortality rate post-esophageal surgery was 8%, which tells us that although the complications may be somewhat similar, at least in our Malaysian cohort, but if someone is not sarcopenic, they have more physiological reserve and they're able to withstand the complications that happen and eventually be discharged and not die within the hospital. So all this data has, of course, been put together in a large systematic review and meta-analysis involving almost 14,000 patients. And basically, if someone is sarcopenic, there is a 1.4 times greater chance of major complications and a 2-fold increase in 30-day mortality. So the catabolic state that is induced by surgery, the immobilization post-surgery, which also involves the respiratory muscle weakness post-intubation, all leads to reduced oxygenation. And this is a vicious cycle that goes round and round, which then eventually leads to us losing our patients. And if you remember that this slide, which I showed earlier, the conclusion basically is that muscle is our insurance against complications which happen post-surgery. And complications is something that all surgeons will have to embrace. It's often said that the only surgeon without a complication is the one that's not operating. And complications, as also shown earlier, tend to be more common the more complex the procedures that we do. So in our hospital, where we receive a lot of very, very complex cases, complication is something that we always have to think about, and we try to do our best to minimize it as much as possible. So the muscle becomes the insurance against complications, as shown here. As to recap, the wound that needs to be healed, the anastomosis that needs to be healed, the substrates for this healing comes from catabolizing our own muscle for this healing. So the muscle becomes very, very important. So in essence, the more muscle you have, the reduced complications and the reduced mortality. And as surgeons, this is something that we are always chasing, to reduce our complications and mortality. So that's the problem that we face. That complications will happen, the one we must embrace. But knowing that we have that muscle can be an insurance against our complications, the proposed solution then is something called pre-habilitation. Basically, if you want to take a car from KL to Penang, you need to give it enough petrol. Or if you're driving an EV, you need to charge your car. So it doesn't make sense if you're trying to go to Penang, but you only charge your car or fill up half a tank and only have enough to reach Ipoh. So pre-habilitation is a way for us to fill up the tank and to charge the car even more. And the definition of pre-habilitation and the solution is that prehab is supposed to increase the patient's physiological reserve. It helps us to prepare for post-operative immobilization, which will definitely happen. It helps the patient to withstand periods of post-operative inactivity, the functional decline that comes with that inactivity, and of course to increase the patient's tolerance for complications, and for us as GI surgeons to increase the perfusion to the anastomosis. So there are two main pillars of prehabilitation. One is nutritional, which involves the uh, science of managing both the patient's macro and micronutrients, and the other is functional, which aims to increase the patient's aerobic and resistance, as well as the inspiratory muscles to reduce the rate of pneumonia. So very quickly, when it comes to nutritional science, we do look at it as macro or micronutrients, and I'll go into it a bit later. But however, this is basically what we do. We decide on the patient's target calories. We then decide on how we want to give these calories, and we always aim for between 25 to 30 kilocalories per kilo per day, stepwise increment, and of course protein, which is very, very important, of about 0.8 to 1.2 grams of protein per kilo per day. And micronutrients is something that we cannot forget as well, because the vitamins as well as the trace elements, they are co-transport factors for the macronutrients. And if we do not give the micronutrients together in our patients, excuse me, then the macronutrients cannot be transported anyway. So as you can see, the trace elements, which are very, very important for all the enzymatic processes that will occur, especially during the catabolic and anabolic phases post-surgery. So in my team, this is basically what we do. This is the flow chart of how we want to provide nutrition to the patient. And basically, we divide into a few steps. The first step is identification of the patient is at risk. Subsequently, we assess the patient after identification. Then we initiate the nutritional intervention. After initiation, then of course there is monitoring of the individual's function as well as their nutritional status. We escalate the nutrition as necessary and then maintain it once we hit 100%. And in the nutritional therapy team, basically this is what we look at. We have a flow chart of how things are supposed to be done. So we start with, of course, the patient's details, what the diagnosis is, what the venous access is, and then all the nutritional parameters and the anthropometric parameters, and finally a plan that will come out after that. So nutrition is great, but we know that nutrition alone without exercise will basically lead to a fat person. And when it comes to surgery, we do not want them to be fat, basically, not just for the technical complexity of it, but we don't want the patient to have non-functioning weights. As mentioned, the aim is to build muscle and not to build just weight. If you're giving them 30, 40 kilocalories of nutrition per day, but they're just lying around, then basically they're all just going to put on non-functioning weights, which is not what we want. We want them to put on functioning weight, i.e. muscle. So functional rehabilitation is very, very important. It comes hand in hand with the nutritional rehabilitation. One cannot exist without the other. As mentioned, if we just give the nutrition without the exercise, then they become fat. If we just give the exercise without the nutrition, then they will never put on muscle anyway because there's not enough substrates. So in the functional rehabilitation, we identify what the areas of weakness are. The rehabilitation should be targeted. It should be functional. It should be realistic because many of our patients are geriatrics, and it should be regimented, meaning that it has to be observed and we have to provide a regime that they follow. To test the patient's function before we start the rehabilitation, we divide it into dynamic and adynamic tests. The 6-minute walk test as well as the CPAT, the cardiopulmonary exercise test, which very kindly has been done by our sports medicine team, who support us very, very significantly in this endeavors. And the adynamic testing, which of course involves the echocardiogram and the lung function test. So what's the big deal about a 6-minute walk test? In a publication in the Diseases of Esophagus by a Japanese group, basically what they found was that if someone could walk more than 454 meters within 6 minutes, the complication rate was significantly reduced, and subsequently also the anastomotic rate. So this seems to be kind of like the golden cutoff for reduction of major complications in esophageal surgery. And and the role of CPAT actually has been very well established. A large meta-analysis involving almost 1,000 patients basically saw that an anaerobic threshold of less than 11 was significantly associated with increased cardiopulmonary complications, unplanned return to ICU, as well as a reduced 1-year overall survival. And this is in patients who undergo esophagectomy, so which is what I do, what I've been trained to do. So all these numbers become very, very important to me. So a CPAP looks something like this. You have an individual that's hooked up to either to a bicycle or a treadmill, and it looks very complex with a CO2 monitor at the face to measure the patient's CO2 output, and all the monitoring leads. So quite a complex looking test. Um, how it's executed, I think we have to ask our sports medicine colleagues about how they actually execute it. But as you can see, there's quite a lot of equipment that's required to perform this test. However, if we do a 6-minute walk test, basically all we need is a couple of chairs, SpO2 monitor, and a measuring tape to measure the distance. So the 6-minute walk test becomes a very simple and cheap test to execute. And as shown earlier, although such a cheap test to execute, such a simple test to execute, it gives us very, very valuable information. And this magic cutoff of 454 is what we always aim for. So whenever the test is executed, this is how my medical officers will report the test to me. They check the patient's heart rate at rest with the SpO2. We calculate what the patient's maximum heart rate should be and what 70 to 80% of the maximum heart rate should be during the test. After they perform the test, what we do is we put two chairs 30 meters apart, and we ask the patient to walk in between the chairs. The chairs they are necessary because they provide a visual aid to the patient. And as mentioned, many of our patients are in their 70s and 80s. So having that visual aid for them to have a target for when they can take a rest is very, very important. The other thing is that we have to monitor the heart rate during the test, because if it starts to go above the 80% mark, then we probably want to start to ask the patient to rest a bit in case something else happens. And the other thing is that if the heart rate does not increase into this range anyway, then the test doesn't become valid because the patient is just not exerting themselves. We want to, essentially the 6-minute walk test helps us to simulate the stress that the patient will undergo during surgery. So exercise becomes a surrogate for the stress of surgery. And if they can tolerate simple exercise, then the likelihood is that they will be able to tolerate surgery. So yeah, so the patients go for a walk. My medical officers will check the heart rate, the SpO2, and they'll do it at 1 through 6 minutes, giving us a total heart rate as well as a distance that is covered. So we can see here that this patient actually can go much, much more. And the 450 meters probably can be much more. And after we identify the areas of weaknesses, we give a regime depending on the patient's fitness. So something like 6,000 steps a day. We ask them to walk up the stairs. We ask them to do some overhead presses, some bicep curls, and then they do this while in the ward. So in the patients that we have identified to be at risk of functional decline, we do end up admitting them to the ward so that we can monitor them while they are performing their rehabilitation. So this is what's been happening in our hospital. As you can see, so on the very left of the image, we have a couple ladies who are performing some overhead presses, and both of them were undergoing. One lady was undergoing gastric surgery, and the lady with the white hair was undergoing esophageal surgery. And again, as you can see, they're quite elderly. So after surgery is done, the team comes and they mobilize the individuals, and even at post-op day 1, immediately after surgery, they are already mobilized so that we can avoid further functional decline. Okay, and this lady walking around the hospital here. So I'm not sure if you may have probably seen her around. Yeah, so she is actually 86 years old, and she was diagnosed with gastric cancer. So very good functional status for 86-year-old. And that's a daughter with her. So we gave her a regime of moving up to 10,000 steps per day. And yeah, so basically every day in the ward, the daughter will take her for a walk. And she's, as you can see, walking the corridors of getting her exercise in. And again, immediate post-op day 1 or 2, she was already moving with the team. And thankfully, she was discharged uneventfully by post-op day 7. Further examples, this gentleman was being prepared for esophagectomy. Yeah, so you can see he's there doing his bicep curls. He's counting his repetitions. Admittedly, his form isn't the best, but this was when he first came into us here. And from the bicep curls, moving to an overhead press, which aims to increase the upper limb exercises, upper limb muscles to help with his respiratory function post-operatively. So on post-op day 1, the team comes and ICU post-esophagectomy, he's already being moved. As mentioned, this is to avoid further functional decline so that they can be discharged as soon as possible. This gentleman was 78 years old. And you can see post-op day 1 in the ICU, he's already moving. By post-op day 2, he doesn't need a walker. And by post-op day 3, he's moving quite fast and barely needs any support anymore. This gentleman was also being prepared for esophageal surgery. We gave him a regime of 4 flights per day of stairs, but he exceeded our expectations, and the surgical ward was on the 7th floor, and he would climb up to the 14th floor 3 times a day, every day. And as you can see, by post-op day 5, he was moving quite well, post-esophagectomy already, with the chest tube and all still sticking out of him. So I've done a very simple audit of my personal data since I've come back to UM, because I just completed my training in 2024. And looking at about 28 cases or so that have been performed, what we can see from these numbers, you can see that immediately the amount of weight loss that they have is very, very significant in esophageal surgery. This is pre-operatively, and that's usually because they have obstructing tumors or they're unable to eat for whatever reason. And they, of course, have a lot of weight loss, and many of them are nutritionally at risk. Some individuals have had neoadjuvant therapy for cancer, and some have not. And what is immediately apparent, if you just eyeball it, of course, I haven't done a thorough analysis, but if you immediately eyeball it, the amount of weight loss they have is kind of correlated to when they will be discharged. So those who are more at risk nutritionally will be discharged later because they require more rehabilitation, and those who are not at risk will discharge much earlier. So looking at the 28 cases or so that I've done since I've come back, so I've been back in UM for 20 months after my overseas fellowship. 28 cases of esophageal cancer. The overall complication rate was about 46%, which is kind of what the international data suggests. So if you recall the earlier studies I put up, the overall complication rate from any sort of esophageal surgery was ranging between 30 to 50%. So ours is around about there. However, what I'm happy to report is that the major complication rate, so the Clavin Dindo more than 3, is about 14%, which is actually significantly less than the national audit. Our national audit gives a major complication rate of almost 40%, but ours is 14. And more importantly, the 30-day mortality rate of surgically related causes at our hospital remains 3.6%. So, so I think of course, we want to, if possible, have a zero 30-day mortality rate, but realistically, that's not possible, especially with the complexity of the surgery that we do. So 3.6% is actually much less than the national audit. So the national audit was between 8 to 20%, as mentioned, but we've managed to achieve 3.6. And that's really only because of the dedication of the team, as well as the support that the upper GI unit has received from the intensivists, as well as the ICU, from the anesthetic teams, as well as sports medicine and all the internal medicine teams who come and really, really give a lot of input, as well as a lot of dedication, their time to our patients. So to conclude, surgery is controlled trauma, and the degree of physiological deterioration is directly correlated to the complexity of surgery. Muscle is our insurance against physiological deterioration, and surgery is the aim of surgery is to restore normal physiology. So the more muscle we have, the greater the likelihood of coming to normal physiology. Pre-habilitation is a combination of functional and nutritional optimization prior to surgery, and it is targeted, regimented, and individualized to the patient. So what is seen in the literature and what we've experienced so far in the real world, especially since a comeback, I think is no longer equivocal. It's a very, very important component of our treatment for the patients. So thank you very much for your attention. I'm open to questions.
All right, thank you, Dr. Wong, for that very insightful talk. I think we have a couple of questions under the Q&A. I'll just read out the first one by Yu Kwen Chan. Dr. Wong, we are working against odds in the management of cancer patients. How do we overcome the psychological resistance, especially the poor drive, the poor appetite, plus the many hospital visits for the pre-habilitation?
Yeah, thank you for the question. I think that's a great question. For the psychological part, unfortunately, as surgeons, that one might be a bit more difficult, lah. And I do get very, very selective with my patients in terms of the resource selection, patient selection, because of the limited resources that we have. So if someone does not show a good psychological motivation to improve, we tend not to operate on those patients because we know that the outcome will be poor. So oftentimes what I will do is I will speak to the patient as well as the entire family. So when speaking to the family, excuse me, yeah, sorry about that. So when speaking to the family and the patient, I will lay out what their cost will be. So I'll paint kind of like the worst case scenario. This is what's going to happen. And it's slightly easier to convince individuals undergoing with esophageal cancer because with esophageal cancer, um, when the lesion is obstructing, they can't eat. And not being able to eat is actually a very big deal for a lot of Malaysians. So I'll lay out to them what the cost will be if they do not receive treatment. And then I will tell them what the cost will be. So in terms of what to expect, what will happen, and what my expectations are for the patient in front of the patient as well as the family. So we kind of come to an agreement of what the surgery, what the treatment cost will entail. And at that point, I usually do ask the patients, do you think you can commit to this treatment cost? And if they cannot, then I will tell them, then unfortunately, I will not be operating on you. But if they can commit, then typically what we do, if they're going for neoadjuvant, we'll see them almost every month to ensure that they are not losing functional status, they're not losing their weight. But if the individual has been decided for upfront surgery, and if they lost a significant amount of weight, then yes, I will admit the patient for up to 2 weeks for rehabilitation, sometimes up to 3 weeks for rehabilitation, but not longer than 3 weeks. The reason why the cutoff of 3 weeks is chosen is because there has been significant literature that published that says that if you cannot rehab an individual by 2 to 3 weeks, then it is unlikely that you can recover them functionally. So any further intervention in that sense would be quite futile. Yeah. So I guess the simple answer is that it's actually a very long conversation with the patient as well as the family. And then it's a very honest conversation about what to expect if they do not receive treatment and what my expectations are for them if they want to receive treatment. And then there's a verbal agreement between myself and the patient and the family uh, on what we expect their commitment level to be. And if they cannot commit, then I'd be very honest with them and say, I'm sorry, but this is no go lah, no point lah. Yeah. So that's how I go about it. And then the poor appetite, yeah. So for the poor appetite, it depends on the cause of the appetite. If it's mainly because of obstruction, which is the majority of my cases, then most of them have a nasogastric tube. In some individuals do not want a nasogastric tube, so I do a feeding jejunostomy for them, insert in the OT. So we remove the psychological need for them to eat because it's regimented. They just have to pour in the milk and then they can rest while that happens. In terms of the many hospital visits, so usually I cap it at 2 to 3 lah. So because once it's cancer, the clock is ticking. If they're going for neoadjuvant, then we can kind of keep an eye on them. But if they're not going for neoadjuvant, like I said, and they are significantly at risk, then I will admit them.
Okay, thanks, Dr. Wong. I think the second question you have already answered. The question was, do you admit all your patients for the purpose of prehabilitation? Do you have anything to add for that one?
Yeah, so almost all actually. Of course, when they come in, the first time I see them in the clinic, I will decide whether they need. So what happens when they first reach my clinic is after the assessment, after deciding that the treatment intent is cure, then a functional assessment is done. If during the functional assessment their numbers are good, then I will not admit them. So if there's been minimal weight loss, if the functional assessment is quite good, if they seem to be very motivated, then usually I will not admit them for rehabilitation. However, if the numbers are not so good or they're quite borderline, then yes, I will admit them for rehabilitation. And that's usually seen in the older populations, those who are in their 70s and above. Yeah, those will get admitted for sure.
Okay, next question is by Prof. Tunku Sara. So, well done. Taking trouble to prepare, starting off a huge procedure on a good footing. I guess that to prepare for any surgery that we may need, including emergency surgery, we need to keep fit and muscular.
For sure. Yeah, thank you for the kind words. I guess it's more of a statement. Yeah, so definitely the fitter you are, the more the higher the likelihood that the surgery will be successful, I would say, and the rehabilitation course will be simpler. Yeah, and the quicker return to normal function.
Okay, the last one is actually also not a question. Excellent presentation, Dr. Wong. You will be my surgeon if I need surgery in that area. I subscribe to the philosophy that you have just shared.
I sincerely hope that I never have to put a knife to any of our colleagues here. Thank you. But thank you for the kind words. Yes.
Okay, I think that's all of the questions for now. Any more from the floor? If not, I think we'll conclude our session for today.
Okay, thank you so much, Mariana. Thank you so much. And I hand the session back to the administrators.